Hello, everybody. Hopefully you're all getting your lunch and settling down. I wanted to welcome you all to this session titled Adapting to Innovation in B-Cell Cancers, Advances with Targeted Therapy and CAR-T, Revisiting the Role of Transplantation. My name is Patel Shah. I'm a professor at the Medical College of Wisconsin. Very lucky to be joined with a friend and colleague, Dr. Patel from Sarah Cannon Research Institute. So want to obviously thank you to the Medical College of Wisconsin, our sponsors, for providing this educational session. There is some polling questions, so please be prepared to use your phone. And if you have questions, submit them, and we look forward to answering them during the question and answer session. And obviously visit us at peerreview.com to get handouts about this session, along with the slides and practice aids, which will be available after the session. So with that, very quick introduction, we do have a question. So the question here is sort of getting you to start thinking about what are some of these unanswered questions in CLL and mantle cell. You can select all that apply and what you look forward to learning in this session today. Perfect. And so, we can see here the different options. Looks like people are interested in learning about all of these topics. And I think all of them have significant value because there's a lot of unanswered questions despite the advances we made in both CLL and mantle cell. And so, I'm going to sort of hand this off to my colleague, Dr. Patel, who's going to get us started with a session on CLL. Right before I do that, I just want to quickly go over the regulatory status of some of the key therapies for relapsed refractory disease. You can see here that there are varying approvals across the United States and Europe. And so with BTK inhibitors, we have obviously 3 covalent BTK inhibitors, all approved for CLL with a varying sort of approval status in Europe. For mantle cell lymphoma, the approval for ibrutinib has been withdrawn, and so we have acalabrutinib and zanubrutinib. We have 1 non-covalent BTK inhibitor approved for different settings in both CLL and or mantle cell. For after often BTK relapse disease, we have 1 BCL2 inhibitor currently approved, and then we have 2 CAR T-cell products. 1 is approved in both CLL and mantle cell, while the other is only approved in relapsed refractory mantle cell. And then during this presentation, we're going to be really focusing on changing the composition of first-line therapies in CLL and mantle cell, talking about time-limited approaches and how to use BTK-based regimens. These developments will have implications on how we use second and subsequent lines of treatment, such as CAR T-cell therapy and or transplantation, and really focusing on personalizing the treatment approach to the individual situation. We've learned now that the genetics and pre-disease characteristics of the patient will often help dictate how we approach these different scenarios. And so with that, I will be handing it off to Dr. Patel to talk about CLL.
All right, thank you very much, Dr. Shah. So we're going to start just by reviewing where we are today and using fixed duration treatment approaches in CLL. So for some time now, there's been a great focus on trying to provide our patients treatment-free intervals, and we have a number of different tools that we can do that. You know this well. This is the snapshot from the most recent NCCN guideline for frontline therapy. And we've had venetoclax and obinutuzumab as a treatment option for a fixed duration therapy about a year in CLL for some time. And now you'll see that there have been some updates in the guidelines recently looking at combinations of not only a BCL2 antagonist, but also a BTK inhibitor. For example, acalabrutinib and venetoclax based on the AMPLIFY data that can be given with an anti-CD20 antibody. Of course, we still have ven and obinutuzumab as well. And then for patients for whom a fixed duration approach is perhaps not as important or not preferred, those patients, of course, we know are well served by continuous covalent BTK inhibitors. This is also true in the circumstance of having high-risk biologic disease, so p53 aberration. We have data sets that, again, support the use of fixed-duration treatment regimens in that setting as well. Slightly different trials, for example, for the combination of venetoclax and obinutuzumab, but nonetheless, the combinations are there for use in patients with all types of biologic risk CLL. In the second-line setting, again, we think again about exposure in the first-line setting as being important and helpful in selecting a therapy in the second line and beyond. For those patients who have not previously had fixed-duration treatment, that might be the first time that they approach fixed-duration treatment with, for example, a venetoclax-based regimen. For patients in whom continuous therapy may be an appropriate opportunity, those patients may then be getting covalent BTK inhibitors for the first time, or we also now have this new option of a non-covalent BTK inhibitor, pirtobrutinib, also given on a continuous basis, perhaps for those patients who started with continuous therapy. You'll note in the bottom inset that we do have combinations of BTK inhibitor and venetoclax as well, also in the relapse refractory setting based on single-arm trials. So across the spectrum of CLL, whether we're talking about frontline therapy, we're talking about the relapse refractory setting, we have options for giving a fixed duration treatment regimen. And then, of course, when we move into later lines, we can think about cellular therapy here, CAR T-cell therapy, again, a form of fixed duration treatment, or the potential for continuous BTK inhibitor with a non-covalent inhibitor, pirtobrutinib. So we have a lot of different options for our patients, and how we sequence them is an important question that the field is trying to answer. So I'll walk you through some of the most recent data updates that were presented at ASH as part of a very large study, CLL17. This is led by the German CLL group. This is in frontline patients who were essentially being treated with one of two fixed-duration combinations, either venetoclax and obinutuzumab, or the combination of venetoclax and ibrutinib, or a third arm with continuous therapy, ibrutinib. And you see here with the initial presentation from these data, the 3-year progression-free survival curves are largely comparable. And so these are overlapping here. And I think what this trial tells us is that the combination of therapies that allows us to achieve fixed duration treatment approaches is not inferior to continuous BTK monotherapy. Recall, this is one of the first trials to look at that comparison, using a fixed duration treatment approach and comparing it to continuous BTK inhibitor. And so this study actually, I think, supports a number of different viewpoints that we can deliver fixed duration treatment approaches like venetoclax and an antibody, or venetoclax and a BTK inhibitor, and expect our patients to have durable responses as measured by progression-free survival here. And you can see that that is consistent across different subgroups. If we look at patients with unmutated IGHV or mutated IGHV, those 3-year PFS estimates are comparable. And if we look at, interestingly, patients with P53 aberrant, this is perhaps where we see some difference. We have known for some time now that ibrutinib or covalent BTK inhibitors do perform particularly well in this setting, and perhaps we're seeing numerically that there are some differences there, albeit the majority of patients are still free of disease progression. And in patients who don't have P53 aberrations, again, consistent responses here. So I think a lot of this trial is interpreted by how you see the world. Are you somebody who favors continuous therapy? This may support your continued use of that. Are you somebody who believes that time off therapy is important for patients? I think this data set supports that we are not shortchanging our patients when we do so. This is a look at the Amplify trial. So this was updated and has now been published in the New England Journal. And to remind you all, this is a frontline trial in CLL looking at 3 combination arms. So the control arm is a standard at the time this study was designed, chemoimmunotherapy either with FCR or BR, the triplet combination of acalabrutinib, venetoclax, and obinutuzumab, or the doublet of AV. The trial was designed to look at the 2 novel combinations compared to chemoimmunotherapy, and you can see here with the progression-free survival curve that the hazard ratio favors either of the novel combinations, either the doublet or the triplet. Now, I'll point out that when we look at PFS, we do see numerically the AVO arm, the triplet-containing arm, does have a higher 3-year PFS. Interestingly, when we look at overall survival, that does not translate to an overall survival benefit. That perhaps actually maybe even can incur some overall survival decrement with more immune suppression and infection risk of the triplet. And if we look at PFS by different subgroups, you can see for the most part here that, again, the results are consistent across different subgroups. Perhaps there is some difference for the higher risk subgroup of patients with unmutated IgHV status, but both the doublet and the triplet outperformed the chemoimmunotherapy control arms. And so while we have known for a long time that chemoimmunotherapy is not our preferred approach in frontline CLL, I think this trial is important because it shows us that we can still achieve fixed duration therapy with a BTK-based regimen and achieve excellent long-term outcomes. Now, I mentioned that when we use a triplet, there is a price to be paid, and so we do see in the AMPLIFY trial that we see an overall higher rate of neutropenia by adding obinutuzumab to the backbone of A and V, and we did also see a higher risk of high-grade infections. But for the most part, the long-term follow-up that was presented at ASH did not identify any new safety signals. And importantly, the way that this regimen was designed, patients have a 2-cycle lead-in with the BTK inhibitor, and the overall risk of TLS with introduction of venetoclax was very low. Other trials that were presented at ASH and CLL that are important here, again in the context of patients with newly diagnosed disease, but also relapse refractory disease, we have the CLL 314 trial. This was a trial to look at pirtobrutinib in comparison to ibrutinib. This is a non-inferiority trial with an overall response rate endpoint. The study included a cohort of patients both with treatment-naive disease as well as relapse refractory disease. I'll kind of highlight here the treatment-naive data, and intriguingly, we do see a higher overall response rate for pirtobrutinib. Again, remember this was a non-inferiority study, but if we look at PFS, we also see numerically a higher rate of PFS, a higher rate for 18-month PFS in the pirtobrutinib-treated patients, suggesting, again, there are differences and important differences between a non-covalent and a covalent inhibitor. There was another study looking at pirtobrutinib in the frontline setting. This is Bruin 313. This is a study that was looking at pirtobrutinib as a continuous monotherapy compared to chemoimmunotherapy in patients who were older or had comorbid disease. At the time the study was designed, again, chemoimmunotherapy with a regimen like BR was common. This is a global study, so while we may not use BR today, I think we can take away that frontline pirtobrutinib also performs very well. So while we have this data for covalent inhibitors, now we have the first trial to demonstrate the outcomes for a non-covalent inhibitor up front. And so a lot of questions about sequencing. We have many different effective therapies for patients with CLL. How do we think about putting all of these together? And that is really kind of the focus of the next segment. So coming back to pirtobrutinib first, I will say we first really got our major experience with pirtobrutinib in the Bruin phase 1/2 study. Recall, this is the phase 1/2 study of pirtobrutinib in a variety of different B-cell malignancies. The largest cohort in this study was patients with CLL or SLL, and we now have a median follow-up of 34 months of patients who received pirtobrutinib in this study to allow us to look at, in the relapse setting, what do outcomes look like. And this is particularly important when we think about the context of CAR T-cell therapy, because most patients today who are receiving pirtobrutinib are likely to be receiving it in a later line setting, for example, after exposure to a covalent BTK inhibitor, certainly, but in many cases also after exposure to a BCL2 antagonist. And while pirtobrutinib is effective in this setting, in terms of activity and response rates, what I think this long-term follow-up data really tells us is that really only a subset of patients are going to have durable outcomes with pirtobrutinib in the relapse refractory setting. And so importantly, we need to think about how we might sequence therapies for patients when they start pirtobrutinib. For example, is this a patient that would be really a good candidate to start planning for CAR T-cell delivery on? When we look at patients by exposure to a BCL2 antagonist, you can see that those patients who have previously had venetoclax, all patients in the Bruin phase 1/2 study had to have a prior covalent inhibitor. Not all of them had to have a prior BCL2 antagonist. But if we look at those who did, you can see here that the median PFS is also shorter. So this is something that I think as a cellular therapy treating physician is really important to recognize, is that patients are often going to be on pirtobrutinib started many times in the community setting, and while it is an effective therapy, it is one that perhaps does not lead to a lot of durability in late-line settings, and so that is the circumstance that we primarily see today. What about venetoclax? So we shared that there are many different venetoclax-based combinations in the frontline setting. What do we know about venetoclax in the relapse refractory setting? I'll really point you to this trial called Venice. So many patients who receive venetoclax as the second-line therapy have had a prior BTK inhibitor. And really the largest data set that tells us about performance of venetoclax in that setting comes from Venice. And what you can see here is perhaps different than people might recognize from other data sets. The median progression-free survival in a patient receiving venetoclax after a BTK inhibitor is 23 months. Recall that the Murano trial, another study that outlines use of venetoclax in the relapse refractory setting, really did not have any patients who had previously been treated with BTK inhibitors. So again, for a transplant and cellular therapy audience, as you are seeing patients referred from your community colleagues who have had BTK inhibitors, who have had venetoclax, I think these data are really important to bear in mind, is that many of these patients in the relapse setting are ultimately going to need a third or beyond therapy, and that is a really important perspective when we think about CAR T cells. Now, on the flip side, CAR T cells are not the only therapy we have, and we'll get to the data for those in a moment. What about retreatment? So patients who get fixed duration combinations that are venetoclax-based in the frontline setting, a question that the field has tried to answer over several years is, can we retreat patients with another fixed duration approach? And we have several different data sets that support that, yes, we can. The activity, the overall response rates can be very high. But I think what's important to recognize about these studies that have attempted to define the value of retreatment is that the follow-up is relatively short, and generally we don't know much about the durability of these responses. And so this is an area where we continue to develop more data. We can also see that while these regimens may be active at retreatment, if we look at depth of response, for example, UMRD rates, they typically are going to be lower. And that really reflects the fact that there is going to be some biologic evolution of the CLL, right? We will not achieve the same depth of response retreating with these regimens that we do in the upfront setting. So again, an important context when seeing patients who might be considered for cellular therapy. I'll highlight an interesting ongoing trial that is being led by Matt Davids at Dana-Farber called Revenge. And so this is a trial that specifically looks at patients who were treated with frontline Ven-G and then giving Ven-G again. There are two different cohorts in the study. For example, if a patient maintained a remission more than 2 years since their last treatment, they are enrolled in one cohort, and then if they had a shorter duration of remission in another cohort here. What was presented at EHA last summer is, again, we see high activity. We did not see emergence of venetoclax mutations or BCL2 mutations that would confer resistance to venetoclax. And these data, again, like those that I shared in the table before, support that retreatment can be an option, but I think importantly, again, we really need to have durability data to tell us if that is, in which cases that may be a reasonable strategy. So that brings me to now, what about the value proposition of CAR T-cell therapy? So you all may know this data well. This comes from the CLL-004 trial of liso-cel, and I want to just provide a little bit of context. At the time this trial was designed and originally enrolling, the backdrop of CLL treatment was largely that many patients in the frontline setting had chemoimmunotherapy. BTK inhibitors were likely to have been a second-line or later therapy for many patients who are enrolled in this trial, and maybe only a subset of these patients would have had venetoclax. So these were very difficult to treat patients, patients who had had clonal evolution, patients who I think biologically are different than the patients we see in the clinic today. And so what we saw from this trial is that the overall response rate was just around about 50%, about 20% of patients achieved a CR. Recall that criteria for achieving a CR by IWCLL criteria is quite stringent and requires no lymph nodes more than 1.5 centimeters on a CT scan, as well as absence of disease in the bone marrow. For that subset of patients who met that deep response, you see here the progression-free survival. If you achieve a deep response to CAR T-cell therapy, you do very well. And again, this is in a very late-line setting. And I think, importantly, even patients who achieve a PR can have a meaningful, durable response to therapy, noted here with a PFS of 26 months, again, in a very difficult population of patients to treat. Of course, CAR T-cell therapy, as you know, is associated with some unique toxicities and some unique delivery considerations. So for a patient to be a good candidate for CAR T-cell therapy, of course, they should have a reasonable fitness. We have to have time to be able to deliver the CAR T cell. These are autologous products that have to be manufactured. And patients often will have to travel to an ATC that is able to deliver this therapy. Now, liso-cel in large cell lymphoma and other lymphoma histologies has been fortunately associated with a low rate of high-grade CRS and high-grade ICANS. That is a little bit different in CLL. I would look at these numbers and say these are still low in terms of grade 3 and higher toxicities, but they are higher than what we see for liso-cel in other B-cell histologies, and part of that may be the compartmentalization of CLL. It is typically heavy involvement in bone marrow and spleen. We can see a higher peak CAR T-cell expansion, things that we know to be associated with higher grade toxicity. So this is an important context for us to think about when delivering CAR T-cells. Now, one of the other important findings from the TRANSCEND study is there was a cohort of patients who were treated concurrently with ibrutinib. And I won't go into all the details of the science here, but basically the idea being that ibrutinib may have some immunomodulatory effects on T-cell fitness and health that may be beneficial. And intriguingly, what we saw in that cohort is that, in fact, we did see a higher rate of complete response. We did also see some modulation in toxicity. And so importantly, a question that's also now emerging is that while we have commercial access to CAR T cells, should we be treating our patients concurrently with BTK inhibitors or in the run-up to collection and manufacture of CAR T cells? And while we don't have prospective data yet to answer that question outside of the data set I shared with you, I think importantly, we're going to see some data at this meeting. So first I'll highlight this abstract number 60 from Jennifer Huang at Fred Hutch, which looks at real-world experience with liso-cel. The first thing I'll point out is that the real-world complete response rate so far for patients treated with commercial liso-cel with CLL does appear to be higher than what we saw in TRANSCEND, so a CR rate of 56%. And interestingly, as pirtobrutinib has become available in this setting, many of these patients had had pirtobrutinib as their immediate line of therapy in the run-up to receipt of commercial liso-cel. And you can see here the complete response rate does appear to be numerically higher. So perhaps there is a modulatory effect for a BTK inhibitor as a therapy before receipt of liso-cel. I'll come back and look at other real-world data that we have. So we do have other real-world evidence for liso-cel. And importantly, the context here is not necessarily liso-cel delivered in the real world, but what would happen if patients were receiving whatever else is available? And this was the focus of a study that Bill Weirder presented. So if we compare outcomes for liso-cel treated patients in the CLL-004 trial, and we look at what would contemporary outcomes with contemporary standard of care therapies be for these patients, that's an important context to contextualize the overall response rate. And you can see for other therapies that are available to patients that are not CAR T cells, the overall response rate is quite poor, 20% compared to 52% for patients treated with liso-cel, and similarly with other efficacy endpoints. So I think context is really important. CLL-004 is a trial of very, very heavily pretreated patients, very difficult to treat patients. So when we look at efficacy outcomes, we have to think about that in context, and then more contemporary real-world evidence suggests perhaps those outcomes are better. And so I'll shift gears, and we want to think a little bit about a case to sort of, I think, highlight some of the questions that have been raised about sequencing. Sarah is a 70-year-old patient, new diagnosis of CLL that requires treatment after a period of watch and wait. She has adenopathy, a good performance status. She has unmutated IGHV status, intact P53, no deletion 17p. And importantly, she wants to maintain her active independent lifestyle, and she wants to focus on a therapy that is time limited. So what are some of the options if time limited therapy is chosen? So I'm going to ask Dr. Shah to help us here. What would you think about Nirav in this circumstance?
So, in this situation, I think she has a lot of options. Yeah, one of the key characteristics I look for in a new CLL patient is do they or do they not have a 17p or TP53 mutation. In that subgroup, often I'm leaning towards a particular pathway. I still favor continuous BTK inhibitor in that group. But outside of that, we have really good data that for standard risk CLL, as you showed in the CLL17 data, there's more than one option that we can offer her. And, it's an older patient and wants time-limited therapy. I think we have two options with Ven-G or BTK, BCL2 inhibitor combination.
Great. And whenever you're thinking about frontline decisions, do you worry about what are you going to do in relapse, or is that a conversation for another day?
So I think that, with more and more therapies being developed, I'm less concerned about that decision making. There was a time when we didn't have non-covalent BTK inhibitors, we didn't have CAR T, and now we have this new class I know you're familiar with called degraders. It's more and more that, I have to worry less about how to deal with it down the road. And what I want to give is the best treatment possible to minimize toxicity and optimize durable efficacy, really, because CLL is a chronic disease and one in which I want people to be able to live a high quality of life.
Yeah, I think that's a really important point. We have so many options that I think we really want to maximize the treatment outcome at the time that we are making that decision. So Sarah, prioritizing time off treatment, decided she wanted an all-oral fixed duration regimen, was treated with acalabrutinib and venetoclax. Now, this is just really a thought process to map out what treatment could look like for her at progression. I mentioned that we think about the time in remission off therapy as being important. One could argue that we don't know what that ideal time cutoff is, but what has emerged in the field in CLL is perhaps if patients maintain a remission for 2 years or longer, that might be a meaningful time off treatment. So one way to think about it is if Sarah was treated with AV and she relapsed within 2 years, often those are going to be relapses that are enriched biologically for the acquisition of adverse biomarkers like p53 aberrations. And that might be a circumstance where you're thinking, okay, we've already had an early relapse with fixed duration treatment. Perhaps my sequence is going to be to use a different class, a non-covalent inhibitor, and make plans for CAR T-cell therapy. And often what happens in practice is we may start the pirtobrutinib, you're having conversations about CAR T-cell, and then ultimately, depending on how patients are responding, might inform the timing of delivery of that CAR T-cell. Another pathway might be the bottom pathway. Let's say Sarah did have a prolonged remission to more than 2 years off therapy, doesn't develop any high-risk mutations or high-risk biomarkers. That might be a circumstance where retreatment with venetoclax-based therapy or perhaps even continuous BTK therapy is a very reasonable option, and then subsequent to that, we might be delivering a non-covalent inhibitor. And so perhaps that's a patient where the delivery or consideration of CAR T-cell therapy could be later on. It could also be after 2 lines of therapy as well, but these are some of the things that I think we're starting to really be more involved conversations with our patients to think about how do we maximize their outcomes. Another option might be, let's say that Sarah had prioritized Ven-G, an infusion and venetoclax. And so here, if we had a remission time of less than 2 years and high-risk features at progression, I would argue that covalent BTK inhibitors are really the most appropriate therapy for somebody who has a p53 aberration. For somebody who does not, any of the venetoclax-based combinations may be very reasonable, again, keeping in mind that response rate is high, durability is a little bit less well known, and subsequent to that, we have the similar options of do we deliver pirtobrutinib and bridge to a CAR T-cell in a higher risk scenario, or do we potentially consider, for the first time in the third-line setting, a covalent BTK inhibitor, and then downstream of that, other therapy options. So with that, I will revisit our case and ask you guys to answer this polling question. So let's reconsider Sarah. She's 70 years old, has treatment-naive CLL, IGHV unmutated, but no p53 aberrancy. And assuming she wants to prioritize time off treatment and wants an all-oral option, which would you choose? Yeah, so looks like the majority of you like the all-oral option of acalabrutinib and venetoclax, about a quarter with Ven-G. Great. And then assuming that you chose a second-generation BTK inhibitor like acalabrutinib and venetoclax, which most of you did, as frontline therapy, how would you plan to treat this patient with early disease progression, say, let's say less than a 2-year remission and the emergence of high-risk features? Yeah, so I think here with high-risk features, shorter frontline remission, most of you are gearing up for CAR T-cell, perhaps using pirtobrutinib to get you some time and disease control coming into that. That would often be my consideration as well. And with that, I'm going to turn it over to Dr. Shah, who's going to take us through mantle cell lymphoma.
Thanks, Krish, for getting us going. And we're going to change gears just a little bit here. Obviously, there are a lot of similarities in how we treat mantle cell and CLL, but obviously distinguish diseases with a different pattern of care. So what we're going to focus on is frontline and sequential mantle cell care, treatment choices with stem cell transplant, targeted agents, and immunotherapy. So this is just, out of NCCN. The guidelines for mantle cell lymphoma are evolving rapidly. Almost every 6 months to a year, you're going to see new data and evidence coming out about how we should approach both the frontline and the relapse refractory setting. Most recent data has really emphasized the role of adding BTK inhibitors as part of the frontline therapy rather than reserving it for relapse refractory disease, which was a paradigm for many years. And so for those younger, fitter patients, an aggressive, induction chemotherapy, the triangle regimen, which uses R-CHOP with a Ara-C-based regimen with the BTK inhibitor based on the triangle study, has become one of those therapies as an option for younger, fitter patients. And then for those who are less fit, there are options to do. You can still do bendamustine rituximab alone, but with the emerging data that came out of the ECHO trial, now approved as bendamustine rituximab with acalabrutinib. Or for those patients who are not even a candidate for chemoimmunotherapy, to get acalabrutinib with rituximab as a combination treatment. We, again, strongly believe that CD20 antibodies have an important role in mantle cell lymphoma, and so maintenance therapy is often offered as part of all of these different regimens as a way to help prevent and limit relapse. So how did we get here? How come we said that BTK inhibitors should probably be part of the frontline therapy? Well, it was through a series of clinical trials, not all of which actually showed a benefit. And it goes to show how you combine these drugs and which drugs you choose does impact the outcomes for patients with mantle cell. So this was a phase 3 SHINE study, and it built on the experience with ibrutinib, which has shown incredible efficacy when it was the first BTK inhibitor approved for relapsed refractory mantle cell, really a paradigm-shifting drug at the time that it was developed. And so he said if it worked well, right, in relapsed refractory, we're going to combine it with BR and go against placebo. So head-to-head clinical trial, BR versus BRI, and you can see here a progression-free survival benefit, but there was no overall survival benefit. And so why is that? Well, it comes down to safety. Ibrutinib, while being a revolutionary drug, we have learned over the years it was a little bit of a dirty drug, had a lot of off-target toxicities that led to other comorbidities, other complications of its treatment. And so you can see here that there were more patients that died as a result of treatment-emergent adverse events in the ibrutinib and BR arm. And so those non-relapse mortality events, they took away from the PFS benefit. So while less people may have progressed, they had other problems that led to their death. And also you can see here more treatment discontinuations in the ibrutinib group because of these adverse events. And so this was actually the trial that sort of led to the withdrawal of ibrutinib in the United States because this was their confirmatory study. So new second-generation BTK inhibitors have come around, and the main selling point of these drugs were that they have a similar signal in terms of efficacy. They're covalent BTK inhibitors, so mechanistically work similar to ibrutinib, but they are more precise. They have less off-target toxicities, and so the ECHO trial was built very similarly to SHINE, in that it was given in combination with bendamustine rituximab versus placebo. And here again, we see a really meaningful progression-free survival benefit. You can see here that the median progression-free survival for the acalabrutinib with BR or triplet type therapy was 66 months versus 49 months in those patients who got placebo. And that led to sort of a risk reduction here. And you can see here that the median overall survival was not reached in either group. And you can see here sort of a 36-month overall survival benefit that at least is trending towards showing a benefit by giving acalabrutinib up front. And why was this? And it's also in terms of high-risk patients, the patients we think that have the highest likelihood of progressing. So these are people with Ki-67, greater than 30%, blastoid or pleomorphic histology, which correlates with an aggressive behavior, and or the presence of TP53 mutation. And so we know that these are patients that do benefit from the addition of novel therapies, and you can see here again a significant benefit in progression-free survival for those patients who got acalabrutinib versus placebo in combination with bendamustine and rituximab. So what I was trying to get to is that the reason this was is that the toxicity profile here was different. You can see here that there really was no difference in grade 3 to 4 toxicities with the addition of acalabrutinib with bendamustine. And so this was a different story than what we saw in the phase 3 SHINE study, and why, obviously, this study has led to the approval of this combination as an option for frontline mantle cell lymphoma. And so what we are specifically looking at are these grade 3 or higher toxicities, and as you go through down these different sort of AEs listed, really you see a very similar profile with or without the addition of acalabrutinib. Now, a big question, because here we are at ASTCT, right? We're transplanters and cell therapists. What do we do with autotransplant? Used to be a mainstay in mantle cell lymphoma. In fact, we used to say, why aren't we doing enough autotransplants in mantle cell? And so we need to go back to the data, and this is a triangle study here. And so the triangle study specifically tried to look, do all patients need autotransplant if they're getting incorporation of a BTK inhibitor in the front line? And so this was a 3-arm study that looked at sort of different combinations of autologous transplant with ibrutinib, autologous transplant alone, or patients who just got ibrutinib without the autologous transplant. And you can see here that the key was actually the addition of ibrutinib. It led to a superior 4-year freedom-free survival if you got autologous transplant with ibrutinib as part of the induction regimen, which I think probably had less impact, but what really mattered was the 2 years of maintenance therapy with ibrutinib that they got subsequently. And then you can see here, there was no superiority of getting an auto without ibrutinib, and actually patients who didn't get an auto but got ibrutinib, you can see here, had an improved freedom-free survival. And then what about in those high-risk patients again, right? So those are the patients that are enriched for mutations that we think are more likely to make them chemotherapy refractory. In fact, for many years now, we sort of stopped auto-transplanting those patients with P53 mutations because, those are types of mantle cell with P53 aberrations that are just less likely to respond to chemotherapy. And so you can see here, right, that in those high-risk patients, greater than 50% P53 expression, the addition of ibrutinib really made a large difference in their freedom-free survival. And that sort of was true across other high-risk features as well, whereas in low-risk patients, you can see here the difference was less meaningful. So that was a European effort to look at autotransplant, and the main message is that, if you put a BTK inhibitor in there, perhaps not every patient needs an autotransplant as part of their frontline therapy. This is the ECOG Akron study 4151, and this was the sort of North American effort to look at autotransplant in a different way. What they did here is they said, you have newly diagnosed mantle cell lymphoma. You can get any induction therapy, but what matters is not what the induction is, but how well you respond to it. And so they looked at MRD, minimal residual disease, at the end of induction, and then based on that, patients were randomized. So if you were MRD negative, you were randomized to getting an autotransplant versus skipping the autotransplant and going directly to maintenance rituximab. For those other patients who are MRD positive or indeterminate, for the most part, transplant was recommended. But I'm going to focus on that primary cohort of patients that achieved MRD negativity. And so looking at Arm A and Arm B, which incorporates those patients who were MRD negative and randomized to either autotransplant plus maintenance or skipping autotransplant and going directly to maintenance. This was reported as a late breaker at ASH in 2024, and you can see here that there was really no difference in overall survival with the addition of autotransplant if you had that deep MRD negative remission at the end of induction therapy. And so the 3-year overall survival was more or less identical, 82% versus 82% in the primary randomization. What about progression-free survival, right? Like, maybe autotransplant had less progression events. And so you can see here, just by looking at the curves, if you were MRD negative, whether or not you got an autotransplant, at least at this early time point of 3-year progression-free survival, did not impact your sort of your PFS. And so arm A of 77% versus 77%. And so this questions, again, the role. Does every patient with mantle cell lymphoma need an autotransplant? One way for us to sort of stratify that is do MRD, and if you're MRD negative, potentially avoid a transplant in that subset of patients. So as we sort of evolve in mantle cell lymphoma, we're moving away from autotransplant. I just shared that with you. Can we move away from chemotherapy like, Dr. Patel has taught us in CLL? And so that's a big question. And so more and more we're learning that maybe we can. And so this is looking at the ENRICH trial, and this basically randomized patients to getting ibrutinib with rituximab. This was done in the UK, where ibrutinib is still commonly used, versus R-chemo, and in the most part it was R-CHOP or R-bendamustine. And for the entire cohort, they found that ibrutinib rituximab had an improved progression-free survival to R-chemotherapy. Now, there is a caveat here, is when you do subset the data, a lot of that benefit was driven from the patients who got R-CHOP. And we have learned over the years that R-CHOP by itself is probably not the best frontline therapy for patients with mantle cell lymphoma. It often needs to be augmented with Ara-C. And actually head-to-head, you can see here with bendamustine versus IR, there wasn't as much of a difference in this patient population. This is a phase 2 Altamira study, and this looked at acalabrutinib and rituximab in combination and sort of had an MRD-based endpoint for those patients who are MRD negative to be able to come off the acalabrutinib. So again, using biomarkers to show deep responses to limit therapy as well. And what they did is they compared it to a data set sort of from sort of the Norwegian countries, looking at sort of those outcomes of patients who were treated with other paradigms prior to this clinical trial. And they showed here that, really a beautiful progression-free survival at 12 months of 90%. And when they compared to this historical data set, that this strategy looked to be better, again, taking the limitations of a retrospective cohort for comparison. So if 2 is good, is 3 better? We heard maybe in Amplify and CLL, 3 might be too much, but mantle cell and CLL are different diseases. And so there is a lot of energy and excitement towards triplet therapy in mantle cell as a fixed duration approach, leading to deep remissions and completely avoiding chemotherapy altogether. I'm not going to go through all these different trials, simply to show you that this is being actively investigated. It's a BTK inhibitor, a BCL2 inhibitor, and a CD20 antibody. What combination, people are choosing in terms of which BTK, which BCL2, which CD20 can be sort of variable. But the main message here is that when you do these triplet combinations, you are seeing incredibly high overall response rates of nearly 100%, CR rates above 90%, deep remissions, and again, avoiding all chemotherapy. So where are we with these sort of next generation therapies? We've shown that BTK with chemo is sort of now one of the frontline standards. BTK with CD20 is being more and more utilized. And we know that these triplets in terms of safety are generally well tolerated in these combination type therapies, but there is going to be cytopenias, infections, and things that need to be taken under consideration. So we now have moved covalent BTK inhibitors into a frontline setting. So what do we do when patients progress after that class of drugs? And so similar to CLL, we have 2 really good options with non-covalent BTK inhibitors and CAR T-cell therapy. So Dr. Patel introduced the Bruin study and talked about CLL. This is the data in mantle cell lymphoma. And so these patients, again, had to have prior exposure to a BTK inhibitor with a diagnosis of mantle cell lymphoma, and then were allowed to go on the Bruin clinical trial and get pirtobrutinib. And you can see here, for BTK progressed MCL, there are actually not a lot of good options even today. And at the time this trial was being done, CAR T was still emerging. And so here, an overall response rate of about 50%, CR rate of 24%, and a PFS that isn't wonderful, but about 6 months, but some durability for that 20% of patients you see that seems to have some tail to this curve. Now, because this drug worked after a covalent BTK inhibitor, that begs the question, could it actually be better as a frontline BTK inhibitor in mantle cell lymphoma? And so there's a phase 3 clinical trial that's been completely accrued. We are waiting for the final results of this study based on a number of events that compared pirtobrutinib to investigators' choice of a covalent BTK inhibitor in the setting of relapsed mantle cell. And this is actually the first BTK to BTK clinical trial in mantle cell lymphoma. Much of that data was actually largely done in CLL. So I think we'll learn a lot from this clinical trial when it reports. Now, we are lucky to have 2 CAR T-cell therapies approved in mantle cell lymphoma with brexacaptagene and liso-cel. You can find the guidelines for these in peer review. And, I think these are well-established therapies. And so the question now is, not how well did they do in the clinical trial, but how are they performing in the real-world setting? And so CIBMTR, obviously the data registry for cell therapy and transplant, asked this question and actually found that it does do really well with brexacel in terms of comparison to how it performed in the clinical trial setting. You can see here similar overall response rate, maybe a better CR rate, and a 12-month progression-free survival that is very similar to what they saw in the ZUMA-2 clinical trial. Toxicity was also similar with sort of high levels of ICANS and CRS. Mantle cell, like CLL, has a circulating component, often high disease burden that can lead to pretty significant toxicity, more so than we see in some other histologies. So CAR T is very effective, can lead to durable remissions. Should it be given before we even expose a patient to BTK, right? And this was the trial question here in ZUMA-2 cohort 3. And basically, these were patients that could have had more than one chemotherapy but were BTK naive. And again, here you see very, very good overall response rates of 78% here and a CR rate of 68%. But again, there was toxicity, grade 3 or higher CRS of 6%. 27% of patients had a grade 3 or higher neurological event, which is pretty significant. Often those patients are obtunded. And there was a non-relapse mortality of 9%, meaning patients dying of complications of the treatment, not from relapsing of their disease. What about liso-cel? So liso-cel is a different CAR T, also approved in mantle cell. And unlike brexacel, it has a different sort of co-stimulatory domain. And so it works differently in patients. And so this is the Transcend NHL study, the mantle cell cohort here. In patients with relapsed refractory mantle cell lymphoma, you see, again, a very high overall response rate of 83%, CR rate of 72%, and a median progression-free survival of 15%. What I would note, though, is that the toxicities were a little bit better with liso-cel, with only sort of 1% of patients having grade 3 or higher CRS and 9% with grade 3 or higher neurotoxicity type events. And so it's good to have more than one option to deal with the wide range of patients we see with relapsed mantle cell lymphoma. And so finally, is there a subset of patients that maybe should get CAR T right away? So there are patients with mantle cell, P53 aberrations, complex karyotype, blastoid physiology. Those patients we know really don't do well, even with our novel regimens. So this trial gave patients acalabrutinib, rituximab, and then quickly consolidated them with brexacel, followed by either maintenance or no maintenance. And so the idea is, can we overcome these negative prognostic indicators by offering CAR T as an upfront therapy? And so this is very, very early data. This was presented at ASH. And so I don't have much to tell you on durability. The efficacy signal is very high. And at least at 1 year, the patients that have made it that far, a lot of them are doing well. We need further follow-up about this approach. And again, I would also point out, you have to make sure the toxicity profile is worth it. You can see here again, sort of grade 3 to 4 CRS and 15%, and significant rates of neurotoxicity events as well. And then lastly, we're at a transplant meeting, and allotransplant doesn't get enough credit. It was the therapy, and to me, probably still the only therapy that is proven to be able to cure mantle cell lymphoma. And so this is looking at a sort of a subset of patients with a TP53 mutation. We know that those are some of the most difficult to treat mantle cell lymphoma patients, and in this cohort of 36 patients, 13 had a TP53 mutation, many years of follow-up. If you sort of could get them beyond 6 months, you don't see late relapse because you're probably getting some graft versus leukemia effect, and you can see here 10-year overall survival of 56%. And so I still do use allotransplant. I use it differently than we did, 5, 10 years ago because of CAR T and BTK inhibitors. But I still think that it is an option, especially for our younger patients with high-risk disease, that we should consider, as a curative intent procedure for mantle cell. So with that, just like Dr. Patel did, I'd like to sort of bring us back together by working through a case here of a patient that is very typical with mantle cell lymphoma, 68-year-old gentleman, stage 4 disease. Mantle often is stage 4, the nature of the beast. He has some osteoarthritis, some asthma, has Ki67 of 30%, non-blastoid, so sort of a standard risk mantle cell, no TP53 aberrations. You met with him, and he's sort of not so sure about transplant. So I guess, Krish, if I can ask you, how would you approach this patient with standard risk mantle cell 68 today?
It's a great question. I think, in general, I've started to really move away from transplant for most patients, and this would be one where I think, the things that stand out to me, so Ki67, whether the cut point is 30% or 50% is a little bit of a debate, but that can be looked at as a potential intermediate to high-risk feature. This might be a patient where incorporation of BTK inhibitor to the backbone of bendamustine rituximab is a good option. He's got some comorbidities, so we're trying to get the longest disease control possible, and so I think I like the combination of BR Acala in this circumstance.
And if I were to switch it up and say, you know what, Krish, he is high risk. He's got P53 mutation and blastoid. Would that change your approach for this patient?
Yeah, I think even more important to incorporate the BTK inhibitor, and then as we know from historical data, patients with P53 aberrations do very poorly with chemoimmunotherapy, so I would probably drop the chemo portion and not subject him to the toxicity of bendamustine. And I don't look at BTK and antibody as a perfect therapy. It's one where you have to make a plan for what's going to happen, but I would maybe even consider adding venetoclax, and so a triplet combination like the Bovin regimen for P53 aberrant disease.
Great, and I think me and you have talked before. We practice very similarly, and so I agree with a lot of your statements. And this is a guy who's, if he's leaning against transplant and he's 68, I would be sort of in favor of that with the data we have by incorporating in early BTK. So just to map this out, you have a gentleman in this age group really hesitating about transplant. We have now good data that if you bring that BTK inhibitor up front, get him into an MRD negative state, we can potentially avoid transplant. And so Acala BR, as you mentioned, Dr. Patel, is a good frontline option. And when they progress, is a conversation, but often pirtobrutinib is started. And I do think that all patients at this point who have seen a covalent BTK inhibitor deserve a meeting with, a transplant-type physician, the group of people that are here today, to have a conversation about the risk benefits of CAR T and whether or not that should be part of their care in mantle cell lymphoma. Now, just switching this up just a little bit, let's say, William was 50 years old and was transplant eligible. You might want to pursue the triangle type regimen. And why do I say that? Because the 3-year freedom-free survival that they have reported is one of the highest I've seen. It's like 87% with the triangle type approach. And here in the US, we just don't use ibrutinib. Often we give acalabrutinib or zanubrutinib with a second generation BTK inhibitor. And again, why? Because for a young patient, I think I do want to offer the deepest response possible. The only thing I would do different, and I'll ask Dr. Patel here, is I'd probably get MRD at the end of treatment, because if they were MRD positive, there is some data from that ECOG trial that transplantation can convert you potentially. What do you do?
Yeah, I think that was an intriguing finding as well, and I would agree checking MRD at that time point makes sense.
And then for high risk, there's data emerging for these triplets. The largest data set is the Bovin study that looks at zanubrutinib, obinutuzumab, and venetoclax, sort of being able to overcome the deleterious effects of a p53. So if you can just pull out your phones one last time here, and we're going to wrap up. And so we have William, 68-year-old. We talked about him, sort of standard, maybe intermediate risk mantle cell lymphoma, doesn't want to do transplant. Which option would you choose? So you have a triangle type, BR with a second line BTK inhibitor, then third line Perto, acalabrutinib BR, chemotherapy, free doublet or chemotherapy free triplet. And so you can see the front line is sequential options here. So, you know, the beauty of all these questions is there's more than one right answer. So no one got it wrong. And, you know, I think we talked about sort of Acala BR as a good option based on the data we have, but all of these are actually very reasonable. Okay. All right. And then had he presented with high risk features, as we talked about a little bit, which treatment pathway would you consider in this situation? So we have the triangle type regimen again, BR by itself, sort of the Acala BR, or would you go to the doublets and triplets because of the TP53 mutation? Yeah, so I think there's more and more data emerging that with P53 aberrations, we do want to move towards sort of novel therapies which can overcome. With that, we do have 5 minutes left, looking at my clock here, and to answer questions. So we welcome you to come to the podium if you do have questions. Otherwise, we have some questions here in front of us that we can work our way through as well. And thank you.
Got 2 questions from the audience.
Hello? Oh, there we go. We do have 2 questions from the audience that came through. I'll ask you this one first, Chris. Do you scrutinize CLL patients more before CAR T-cell therapy because the side effects are higher? So are you more worried about the adverse events in CLL?
Yeah, it's a great question. I think, you know, just to remind you, CLL patients are typically older anyway. They have more comorbid illnesses. It's really the neurologic toxicity that I worry about more. So I don't know that I scrutinize them more, but I think the counseling and education is really important and making sure they have the right caregiver support, the right systems around them. I will say that part of that also depends on what treatments they've had leading in. If they haven't had pirtobrutinib, I try to use pirtobrutinib to debulk disease. That may help us to kind of ameliorate toxicity. So I think we just take a more careful approach and provide a lot of counseling to those patients to try to lessen the chance that they have high-grade neurotox.
I do see a question at the podium.
Patients had a couple questions about mantle cell lymphoma. Yep. If you have a patient who is, say, fit, 60 years old, no P53 mutation, but not interested in transplant, do you have any preference for a more intense chemotherapy backbone like triangle plus acalabrutinib versus BR plus acalabrutinib?
Yeah, I mean, that's a great question, right? So those regimens were not really compared. And if you look at them, they studied different patient populations, right? You know, one was built specifically, you had to be transplant eligible in Triangle because it was randomizing you to transplant. We know separately from other data sets that the incorporation of Ara-C has always had an important benefit. And so, and again, looking at sort of the 3-year freedom-free survival, my personal bias is a triangle type approach induction. Because again, like, what do you want to do in mantle cell? You want to maximize that first sort of, you know, disease-free interval to the best that you can. And so I think that, you know, using a triangle type approach, now I'm going to be honest, I do a modified triangle. I don't like to give cisplatin because it causes kidney problems. And if I box their kidneys, I may limit them from getting CAR T or other therapies in the future. So often we do that DHAX or Ara-C alone. But that's sort of the approach I have been doing. I don't know if, Chris, you feel differently or would do something different.
Yeah, I think very, very similarly, if it's a 60-year-old patient who would be a candidate but doesn't want transplant, I think that's where, you know, the triangle data without transplant really shines as well, and I would probably favor the same, and we often use carboplatin or oxaliplatin. Yeah.
Oh, thank you. And if you have someone who is treated with a triangle type approach, 2 years of, say, acalabrutinib for maintenance relapses some point after that, would you go back to something like acalabrutinib, or do you go straight to pirtobrutinib?
So that's a great question, and that's actually, I think, a really important question that we don't have a ton of data for. Are these patients BTK sensitive? I think I would start with the covalent BTK inhibitor, or potentially we have a lot of data for the doublets and triplets, so you could argue doing that. But these are patients that I'm going to be watching a little bit closely, simply because I don't have the personal experience, and I don't think we have a ton of real-world data either to say, hey, oh yeah, the BTK inhibitor is going to work for another 5 years. So I think I'm going to put them back on a BTK with a close eye so I can quickly shift to CAR T if we need to.
Thank you.
You want to handle that last?
Yep, I think we've got time for one more. This was a question about CLL. Do you have recommendations and/or data to support optimal timing, sequence, and duration of BTK inhibitors with CAR T-cell therapy for CLL? I'll just kind of quickly highlight what was done in the CLL-04 study, and then we'll ask Dr. Shah. So in CLL-04, essentially patients who were on a BTK inhibitor and either progressing or had failed to achieve a CR, or who had been on one in the past, weren't on one but could tolerate it, were enrolled. And essentially what they did on this study was to start the BTK inhibitor, continue it through leukapheresis, and through at least 90 days after the CAR T-cell was delivered. Patients could continue it for longer. That was up to the investigator. So that's one, I think, framework. But it's a great question because we don't know what the optimal approach is. So what do you do, Dr. Shah?
Yeah, so I think that we are doing a lot of BTK bridging to CAR. So, and if they progress on a covalent, we are doing a PERTO for disease control. We actually have an IIT where we're evaluating the role of pirtobrutinib and how it may modulate T cells, and we hope to share that data in the future to see if it actually can improve the quality of the CAR T and explain why we're seeing better outcomes. Post-CAR T, outside of a clinical trial, I don't generally do maintenance BTK, simply because I don't think we actually know. There was some interesting clinical trial data of zanubrutinib with CAR-19, followed by zanubrutinib maintenance in diffuse large B-cell lymphoma that was presented at ASH. And so those data sets are emerging, but I haven't done a ton of maintenance outside of the context of a clinical trial where we are obviously describing the risk and benefits and trying to learn something from that at this time, but definitely everybody's getting it as a bridge. Great. Well, listen, thank you all for your attention. We'll be up here for a few more minutes if you have any questions you'd like to ask us, but we hope this was educational, and enjoy the rest of the meeting.